Hello and welcome to the Spinal Cord Injury Forum. I am Stephen Burns, Medical Co-Director of the Northwest Regional Spinal Cord Injury System. The forums, the video recordings, and our online media content are made possible by a grant from the National Institute on Disability and Rehabilitation Research. Tonight we are pleased to have three individuals from the Rehabilitation Institute of Washington giving a presentation on multidisciplinary management of pain in spinal cord injury. Dr. Kathleen Burgess, physiatrist, Randy Hermans, physical therapist, and Dr. James Moore, psychologist and director of the Rehabilitation Institute of Washington. There'll be time for questions after the presentation. Now please welcome our first speaker, Dr. Kathleen Burgess.
Hello there, very nice to be here today. This is a picture of where we work at, me and my colleagues. We basically deal with injured workers, people who have chronic pain. They're almost all seen with a team approach between this group, the therapist, the psychologist, and a physician. This is who we are. Today I'm going to talk briefly about different kinds of pain, acute pain, and then chronic pain. Discuss briefly about why chronic pain develops. Talk about some of the different kinds of pain in spinal cord injury, and then some of the medications that are used to treat it and other treatments. So first, what is pain and why do we have it? Lots of people have tried to define it. The most well-known is by the International Association for the Study of Pain. And they describe pain as unpleasant, sensory, and emotional experience associated with actual or potential tissue damage. And the reason why this is important is although it includes sensory information, that means what my nervous system is telling me, it also includes an emotional component. And that's for everybody, and I would say in all circumstances. It also can be actual tissue damage, but sometimes people end up getting the pain sensation and a pain signal even though no actual tissue damage has happened or is no longer ongoing. And then, of course, the goal of pain is protection. Best case scenario, your brain would like to absorb the information about its environment, make sure that it knows that it's safe, there's nothing life-threatening going on, and then it has mechanisms to actually turn pain off. And that would be its best case scenario. So there's different kinds of pain. One way to categorize pain is to lump it between acute pain and chronic pain. Acute pain is kind of the standard pain that we think about. You have an injury, it usually hasn't been very long. You go in to see 5 doctors and every doctor says, oh yes, this is a broken elbow, this is tendonitis, it has a very definable source of pain. Typically when the injury heals, your pain goes away. You might need opioids, but usually that resolves in a couple of weeks. This is the easy pain that isn't any trouble. Sometimes pain becomes chronic. And the definition of chronic pain is any pain that lasts beyond the normal. You can see what a vague, almost, I don't really want to use the word bogus, but just a vague description of what it is. Normally we think about pain that's been going on for more than 3 months. Kind of gets itself lumped into the chronic pain mode. Frequently, you go into 10 different doctors, and now you might get 10 different answers. One guy says it's this, the next person says it's that. Frequently, when pain becomes chronic, it no longer has a very specific source that's generating the pain. Frequently, chronic pain is difficult to understand by physicians who don't deal with it a lot. It's poorly understood by patients, and it can be a very frustrating situation. So when pain goes from acute to a chronic, what's happening? Why does this happen? This is really the million-dollar question. It's an area of intense research right now. Person who figures this out is, going to be a millionaire. But in general, we think that it's abnormal changes to 2 different parts of our nervous system. The sensory nervous system that's bringing in information, and then the motor system that has to do with moving your body. So normally when there's an injury, there is damage, either mechanical pressure to a tissue, chemicals from the body that were released due to the injury that injure the nerve. The nerve takes this information and it's going to go to the spinal cord. In the spinal cord, it connects with another nerve, and then it goes up to the brain. In the brain, it's altered by a variety of different parts of your brain, and then ultimately it will land up here in the top part of your brain where you recognize it as pain. When pain is brand new and acute, these chemicals that are released from the tissue, they make the nerve fire faster, fires more frequently, and it's easier for it to fire. So when you touch it lightly, for example, if you have a big swollen finger, you know that just to touch it lightly now is going to send this big pain signal. Because that nerve, it's all revved up, it's more easily stimulated. There are some cells in the spinal cord that are helper cells to these big nerves, and sometimes they contribute to the ongoing inflammation. They give out amino acids that are excitatory, they give out chemicals that make it inflamed, and again, it helps the nerve send this signal that it's injured. Initially, this is great information for the body. It means that you won't move your joint as much, you'll protect it, you'll take some rest, and hopefully that will promote healing. Somehow, however, when this system gets going, it forgets to turn itself off. And these nerves that come all the way out to your skin, they are revved up and they will keep going more easily. In addition, in the spinal cord, when pain has been ongoing for a long time, that can also have its own changes. Sometimes the area in the spinal cord that is receiving the signal, it will sort of span out. And now areas that were next to the injury come in, and they end up connecting with these nerves that carry the pain signal to the brain. And this explains why sometimes with chronic pain, the person's pain spreads. Maybe started at their foot, and now it's their ankle and their leg, even though they never had a new injury. In addition, nerves that normally carry the soft touch or just light touch signal, they come in and now they start to either act as if they are pain nerves or connect with other parts of the nervous system that then connect with pain signals. And then things that normally wouldn't be painful, like the light touch of your sheet, the wind blowing by you, now those signals come in. They're connected to signals that carry the signal of pain to your brain, even though we know that that wasn't really a sensation that normally would injure somebody or cause pain. That's called wind-up. That's also called chronic pain. There's a lot of research into this area. Again, in principle, it all started to protect the nervous system. In practice, it's not really clear why it sort of gets stuck in this ongoing situation. In between these peripheral nerves that get inflamed and the spinal cord, there certainly can be a situation with chronic pain where the pain signal is now being perpetuated by changes in the nervous system, and it's no longer connected to an injury out in the periphery. In addition, at the very top part of your brain, you have a map of your body. And in principle, it's sort of the same for everybody. If I pinch somebody's thumb really hard, when we look at it with a special kind of MRI, the same part of my brain is going to light up that's connected to my thumb. Recently, they have found that this part of the brain actually changes with time and can change with injury. For example, people who do Braille and use a lot of stuff with their thumb, the part that corresponds to their thumb might get bigger than other people's area. In addition, sometimes when there's pain, the area might expand and be bigger than it would have normally. Sometimes when there's an amputation or lack of sensation, areas nearby will sort of come in and take up the space that used to be taken up by the other body part. And then finally, and you might know more about this, Dr. Burns, but I was reading that they did one study in people with spinal cord injuries, and they saw that people who didn't have any sensation did have this phenomenon where areas nearby would sort of scoot into the part of the brain that was missing or lacking from the periphery. But then people who had pain, it was more likely to happen. So they're not quite sure how they're going to use this information to help treat pain, but it certainly is something that they have discovered, illustrating that pain has turned out to be way more complex than anyone ever thought. The whole acute pain where I have an injury, when that's over, my pain is gone. We know that that happens sometimes, but complex pain really is participated in by a lot of different areas in your brain that change with time. Additionally, we know that when the pain signal goes up to your brain, it sort of takes a side trip, and it will go through multiple parts of the brain where memory and emotion are stored. That changes the pain signal and then alters it before it gets up to the top part of your brain where you can sense it. So again, just speaks to the complexity of pain. In the motor system, the part that's contributed to by the muscles and activity, we know that pain can impact the way people move. Sometimes when there's pain, it can make people not want to move, whether that's subconscious or not. Sometimes this impact on the way that we move can make people have abnormal movement patterns. The easiest one to think about is a limp, that initially people start limping in an attempt to decrease the amount of pain they have. However, we know then when people develop abnormal body patterns, that in and of itself can contribute to pain. We know that fear and anxiety also affect movement and how people move. And then we know with time, even just like when I walk, I don't have to think about walking. It's almost a subconscious pattern. Not using a limb that's painful can almost become a subconscious thing, and people can learn how not to use something. We believe that that's to be detrimental because we know that all joints were meant to move. So what happens in spinal cord injury? Spinal cord injury, a high frequency of pain. Sometimes it's due to injury to their spinal cord. Sometimes it's due to muscles and tendons. A small minority have pain that's so bad they're unable to do most activities. Lots of different kinds of pain after spinal cord injury. Similar to dividing it in between acute and chronic, I'm going to change it to pain that comes from your nervous system and then not nervous system pain. We call this not nervous system pain, nociceptive pain. And that comes from injury to muscles, to tendons, could be a burn. This can be acute or chronic. And then we tend to define neuropathic pain, which you might have heard described as pain that comes from an injury to the spinal cord or the big nerve roots. After spinal cord injury, this can occur months or years later. Now, people have tried to classify what kind of pain happens after spinal cord injury. And in principle, this is so then when we focus treatments and we see if things are working, we will know if it worked because everybody sort of had the same kind of pain. In reality, we know that this is a great thing to try, but frequently pain doesn't always fit into such an easy category. But in general, this is one way to classify pain after spinal cord injury. Nociceptive pain, meaning pain to muscles and tendons or something happening in your gut, and then pain that's due to the spinal cord injury, either at the level of the injury or below, or there's other kinds of injuries that happen to nerves. Different kinds of musculoskeletal pain after spinal cord injury. Certainly early on it can be from the spine fracture or from the injury itself. Shoulder injuries can develop when people are using a wheelchair a lot or doing transfers. Muscle spasms, sometimes arthritis, things that people may have gotten even had they not had a spinal cord injury. Low back pain is a very common one. Overuse injuries, again, related to movements that your shoulder would not normally be doing. A poor fitting wheelchair, improper transfers, and then disuse or contractures. And again, this gets back to when our brain has given us a signal that something hurts, and initially it wants us to stop using it, and that's great initially. When pain becomes chronic, usually that mechanism is not as helpful. When people don't use a joint, an elbow or a shoulder, a hip or an ankle, if you don't range it all the time, it will get stuck there. And somebody who's never been injured it will get stuck after a certain period of time. People who are injured, it gets stuck faster. So just a reminder that, no matter what somebody's condition is, to gently arrange the joints every day is an important part because the contractures can end up being painful. Pain at in the musculoskeletal system, it could be above your injury, it could be below. Frequently it's related to movement. Sometimes this is easier to find because it's tender. You can push on it and find it. They might do an X-ray and an MRI and come up with more of a diagnosis. And if it's up here where people still have sensation, frequently that's more easy to define exactly where it is and how it feels. People can also get pain after spinal cord injury from inside their guts, having to do with their bladder, urinary retention, a urinary tract infection, a kidney stone, constipation, appendicitis, just like people without spinal cord injuries might have, stomach ulcers. These kinds of pain, they might not present similar to an unspinal cord injured person. And this is where, just like other parts of your care, you'll have to remind people, you might have to remind a physician to think about these things. Because sometimes a kidney stone isn't going to present as back pain. It might present as increased spasticity in your legs or increased leg or back pain that doesn't seem to be related to the gut. Neuropathic pain that comes after spinal cord injury, how does it happen? Loss of blood flow to the spinal cord, mechanical traction on the spinal cord. Sometimes people can develop a syrinx. Does everybody here know what a syrinx is? Okay, so in the middle of your spinal cord you have a very tiny canal that's running that has fluid in there. Sometime after spinal cord, as the spinal cord is recovering, there might be, that might start to expand as it collects with fluid. Sometimes that doesn't mean anything. Sometimes it can push on your spinal cord and then give you more weakness or pain. And so a syrinx that comes up can be a new finding, and that might be associated with pain after, years after their spinal cord injury. And then, of course, any kind of bone pushing on your spinal cord would contribute to neuropathic pain. What does neuropathic pain feel like? Anybody here with neuropathic pain want to say what it feels like? Okay. Below the level of injury, it's frequently described as burning, tingling, numb. It might be aching. This can be on both sides. This might happen months or years after the injury. And it might be associated with something called allodynia, where you just touch your leg lightly, and that's a painful sensation. At the level of injury, it can be on both sides. It can be the situation where normal sensations are more painful, and it can also occur that things that are normally painful are even much more painful. Sometimes at the level of injury, it might be that just one side of the spinal cord or the nerve root coming out is injured. That might feel like pain that comes in a band around your body. It might be radicular, meaning that it goes down your leg or down your arm. When it's radicular, although we call that neuropathic, it has a very specific pattern. And again, this can occur weeks to months after the injury. A couple kinds of neuropathic pain or nerve injury pain that can happen after spinal cord injury, but it's more sort of related to life. Diabetes, central post-stroke pain, and then compression of a nerve. The most common one is carpal tunnel in the wrist, also ulnar nerve at the elbow, either from resting your elbow down or this kind of movement. Sometimes people can develop something called tarsal tunnel syndrome in the foot. Lots of different medications are used for the treatment of pain after spinal cord injury. I could separate them out to the ones that we normally use for musculoskeletal pain and the ones that we normally use for neuropathic pain. We could also think about this as medications for things that are acute and new, and medications for things that are chronic. What we do working with injured workers and with patients who've had pain for a very long time, this categorization sort of uses its usefulness because frequently you have to try a lot of different medications in order to get some assistance. So different ones, everybody knows about anti-inflammatories, acetaminophen, anti-seizure medications such as gabapentin, that's also called Neurontin, and pregabalin called Lyrica. These can be very effective for numbness and tingling, can also really help with sleep, and we know that any sort of sleep irritation or a disruption can contribute to people's pain. So people with chronic pain frequently have physicians that work with them on getting their sleep normalized. Other medications include muscle relaxants like cyclobenzaprine or methylcarbamol. I forgot to add ones like baclofen and tizanidine, used more for spasticity. Sometimes those can also be used for sort of muscle pain or for sleep. Antidepressants such as Cymbalta and amitriptyline. Now, opioid medications like Vicodin, Percocet, Loratab are all called opioids. They are frequently used after spinal cord injury, and they're frequently used for all kinds of, they're not so frequently used after spinal cord injury, but they can be used for all kinds of different kinds of pain. These have some particular side effects, including decreasing people's respiration, causing constipation, maybe making somebody have a low blood pressure. For these reasons, they might not be used quite so frequently in people with spinal cord injuries. Are they helpful? You know, sometimes they are. Frequently, they are best after a brand new injury. When things become chronic, these definitely lose their effectiveness. Now we've seen too, when I was telling you about the brain map, the body map in your brain, the people who take chronic opioids, sometimes that can change that map as well. It can change the environment in your spinal cord. And in general, for things that are chronic, there's becoming a trend away from using opioids for pain. Other kinds of medications can be used for pain after spinal cord injury that are into the spinal cord, such as lidocaine, ketamine, baclofen, clonidine, and morphine. These kinds of pain procedures are not 100% useful, and they're typically come at the very end of a long set of other things that have been tried. Other kinds of treatments for pain, deep brain stimulation, transcortical stimulation, spinal cord stimulators. Again, it would be great if they worked 100% in all people. They don't. They have some side effects and typically are used more for more disabling pain. Other treatments for pain include exercise, massage, acupuncture, and psychological interventions. Again, probably not one study that showed one of these was great for everybody. When pain becomes chronic, people really have to try a lot of different kinds of things to figure out what might work for them. The psychological interventions are critical. As I mentioned earlier, all pain signals come through the brain and are modified by the part of our brain where memory and emotion are stored. All pain has a psychological component to it. And so when people's pain becomes chronic, just like you would look at surgery, injections, medications, different kinds of treatments, psychological aspects to pain should always be included. So in summary, people who've sustained a spinal cord injury may experience pain syndromes that are typical to other people that are not related to their injury. They might have syndromes related to their injury, and some of these might present differently and need really a trained person to think about them so that they don't get overlooked. Once pain becomes chronic, it really is difficult to treat for everybody. Multiple medications are usually tried. Alternative treatments are tried. This is a very hot topic of research too. With the new brain scans that they have, they are really learning a lot about all the different parts of the brain that are contributing to pain. As I'm sure you've heard from other physicians and care providers, really, even chronic pain, this is a time for you to remember that you're the expert regarding your condition. You might have to educate other people on it. Don't ever underestimate the rules of general health. Eating right, getting enough exercise, getting enough sleep, trying to manage the stress in your life so that it's not contributing to a revved up nervous system that then contributes to pain. Always try to include time for psychological care, identifying the sources of stress. I think Jim's going to talk more about this. Having a social circle, having activities that you like to do. Believe it or not, it seems minimal, but all of those really can contribute to controlling pain.
So our next speaker will be Randy Hermans, a physical therapist with the Rehabilitation Institute of Washington.
Thanks. It's a pleasure to talk to you today. I'm a physical therapist, and so I tend to work in the context of exercise, but what I enjoy most about working with folks with chronic pain is that it really does take a team approach. So if you leave here with some action items today, just be aware that if you're dealing with chronic pain and you're looking to get some help, you really need a team approach with people to help you with that. You need a physician kind of covering the aspects that Dr. Burgess covered. You really should have some contact with a skilled therapist, whether it's a PT or an OT, helping you with your movement, but also keep in mind chronic pain aspects of movement, which I'm going to talk about, and then getting the psychological support in the areas that Dr. Moore is going to talk about. Lots of good information about exercise being an important aspect of managing chronic pain in the general population, but also a couple good pieces of literature talking about exercise helping spinal cord individuals as well. And so a couple things you noted here are circuit-resistant exercises, which would be basically different types of strength training, and then a home exercise program involving some flexibility and basic strengthening exercises. So I'd like to talk briefly about different types of exercise and how you might use that to approach one aspect of managing your chronic pain. Lots of different types of exercise, and I tend to break them down into some different groups. One would be relaxation and flexibility types of exercise. So generally at the beginning of when you're first injured, you have intimate association with both physical therapists and occupational therapists, and primarily oriented towards teaching you to move safely and care for yourself. Once you've attained those goals, maybe you have less interaction with those folks. But if you're dealing with a pain problem, it might be time to reconnect with someone or establish a relationship with someone that can help you really set up an appropriate exercise in the context of managing pain, and asking about some relaxation and flexibility exercises. In our clinic, we do about stretching, certainly a full body stretching program every day. This not only helps keep the muscles in the joint slimmer, but from a central nervous system sensitivity that Dr. Burgess was talking about, where normal things start to create that pain. It seems like repetition of normal things on a daily basis seems to kind of help address that wind-up situation where as you do things that are initially uncomfortable but are safe and normal, if you do them repeatedly, suddenly the body begins to pay less attention to them. And that's one aspect of managing your chronic pain. We do things in addition to regular exercise, such as just basic yoga activities, Tai Chi. So there's a lot of different avenues of relaxation and flexibility activities out there for you that will appeal to your interest. So talk to your therapist, or if you don't have a therapist that you're working with now, maybe reestablish contact with someone that your physician can recommend to you, and have them evaluate your relaxation and your flexibility program. Benefits of these activities include reduced pain, of course decreasing muscle tension, and perhaps dealing with some spasticity, certainly decreasing stress and perhaps improving sleep. Basic diaphragmatic breathing can be an important aspect of relaxation, whether you do that through a relaxation tape or some sort of yoga style. Normalizing range of motion in all the joints is important for the next part of what I'm talking about, which is maintaining appropriate posture and appropriate stabilization. Stabilization, or good posture, or body mechanics just basically refers to using your body in the environment where it's the strongest. And in wheelchair users, we're certainly talking about the shoulder, but also the trunk and the head. All joints in the body, whether it be a finger or a wrist or a neck, have a position where there's the least amount of stress across the joints, and where the muscles that control that joint are the most effective. And since many things in life take us out of those positions, we want to do exercises and activities that really help us reestablish those positions, so that as we go through our normal day-to-day activities, our body knows how to maintain those positions. So for wheelchair users, it's particularly important to have good stability around the shoulder girdle. So this would be scapular styles of exercises, certainly exercises for the rotator cuff, exercises for the elbow and wrist. And everybody's a little bit individual on what are the best exercises based on their presentation, based on how long they may be using their wheelchair, based on what their lifestyle activities are, based on what type of wheelchair they're in. So this is the time where you really want to get an individualized program and again, look at meeting with a therapist that's kind of skilled in helping you devise that, and then just maintaining a regular postural and stabilization exercise as part of your normal daily routine. Strength training is also an important component of dealing with chronic pain, not only to strengthen and allow you to do the things that you want to do, but also for, again, looking at this kind of wind-up phenomenon where in our population groups, simple activities and maybe even like vacuuming or cooking, which of course aren't injuring the body, become oftentimes extremely painful, and that can be can be significantly disabling, but those things don't have to be things that you avoid. They can be things that you can get back to. You just need the strength to be able to do that. And so a regular repetitive strengthening program not only help give you the strength to be able to do those normal activities that you want to do, but done repetitively and consistently over time can also help deal with more of that central nervous system sensitivity where the spinal cord and the brain are sending pain signals even in the presence of normal stimuli. So these benefits, including improved posture and body mechanics, which are important, improved functional capacity level, which is extremely important for self-care. Strength training can improve lean body mass and help with your metabolism, and then also decreasing your risk for injury. So in a wheelchair user, an injury to the rotator cuff or the neck or shoulder can be a significant impact on your function. And so thinking about just getting that area as strong and as stable as you can would be extremely important. And let's not forget cardiovascular exercise. So cardiovascular or aerobic exercise using large muscle groups in a repetitive fashion at low level to try to ultimately elevate the heart rate to a level that generally thought of for about 20 minutes to release some of those natural endorphins in the brain that can help with mood, can help with sleep, can help with pain management, as well as a variety of aspects of health. And certainly spinal cord individuals, for most folks, are going to be able to find something that is available in this arena, and this is where a skilled therapist could also recommend something for either a piece of equipment or a location where you might be able to pursue that. And again, reviewing the relevant benefits from cardiovascular exercise, helping with chronic muscle pain, dealing with depression and sleep, and decreasing overall risk of injury and disease. So I guess if I had a take-home message for you today in regards to exercise, recognizing that we're not just exercising for basic flexibility and strength, but in the context of managing chronic pain, we're also exercising to desensitize the whole system to movement so that your everyday normal activities become less painful and that your body ultimately is stronger and more able to take on the challenges that you need to on a daily basis. And really your best person to do that would be a PT or OT, perhaps someone that you've worked with in the past. And if you haven't reassessed your exercise program recently, now might be the time to do that. Okay, so I'd really encourage you to do that. That would be my take-home message for everybody today.
So our final speaker will be Dr. James Moore. He is a psychologist and the director of the Rehabilitation Institute of Washington.
Thanks, Steve. It's a pleasure to be here with all of you. Thanks for coming. I don't know if you can read it very well, but the subtitle of my talk is Making the Best of a Bad Situation. And I think, unfortunately, most of the people that I see in my practice have had serious injuries, and they've had pain for long periods of time. And not everyone, in fact, very few people completely overcome their pain problems. So the reality is I think you have to live with a certain degree of pain. And my job in working with individuals who have chronic pain is to really help people make the best of a bad situation, to manage the pain so that you don't become depressed, that you're not grouchy and irritable, that you don't stop moving entirely, so that you don't let the situation interfere with your relationships with others. To try to cope with it in a way that allows you to have a good quality of life. This is a drawing by René Descartes from the early 1600s. And this shows his depiction of the nerve pathway carrying pain signals to the brain. And Descartes thought that it was almost like a mechanical connection between the point of an injury and the brain processing those signals. And it was almost like pulling on a rope and ringing a bell. It was automatic, and that the amount of pain you had was supposed to be in direct proportion to the degree of injury that you suffered. And he actually felt that he separated the brain from the mind and said that cognitive processes, emotional factors, psychosocial factors had absolutely nothing to do with the experience of pain, that it was simply a mechanical process. And this kind of led to the classic medical model that was in existence probably for the next 350 years. It's only been the last 30 or 40 years that we've become much more aware of the fact that psychological processes, emotions, thought processes have a huge influence on how much pain people experience from a given injury. There's very little correlation between the severity of an injury and how much pain it causes. So pain, as Dr. Burgess said, is a very complex process, very difficult to understand, but clearly it's not this direct pathway. She already gave you one of these definitions. I was wanting to make the point that we now perceive pain to be both, it is an unpleasant sensation, but it's combined with both physical and emotional components. And the brain doesn't always process all the pain signals that you receive. So people who have chronic pain, they have injuries 100% of the time, but they may go through periods of time when they don't hurt at all, or when their pain is only 50% of what it is some of the times. And then there are times when it's much worse. And those changes in pain are influenced by lots of psychological processes. Again, the difference between acute pain and chronic pain has already been discussed. The basic point I want to make is that acute pain is influenced mostly by the injury itself, the tissue damage that people experience. Chronic pain is much more influenced by all those other psychological factors. This is a nice heuristic model that's been around for a long time. It was actually, I think, developed initially at the University of Washington to kind of help people understand the different components of a chronic pain problem. So everything begins with an injury or tissue damage, and typically when you have an injury there is pain sensation that results from it. But not always. You might have an injury, and a minor injury anyway, and be so distracted by something that you're doing that you don't notice it at the time. People in horrific accidents might be so overwhelmed by the danger and the people with them and determining whether they're safe that they don't realize they fractured a bone until, you know, an hour later when the emergency has passed. So you don't necessarily always have pain in direct proportion to the tissue damage. When you do have the pain experience, especially a chronic pain experience, we all have thought processes about that pain. So you all have a complex set of ideas and beliefs about your pain, whether your pain is caused by some undiagnosed medical condition, whether your pain is something that is going to greatly impact your life, whether your pain is something that's treatable, whether your pain is something that other people believe you have, whether other people care, whether your doctors really are trying their best to treat your pain. So you have lots of ideas about your pain, and how you think about pain can influence how you respond emotionally. So people that have very pessimistic, negative, hopeless outlooks are much more likely to become depressed. People who believe that people don't really care, they're not interested, they're not trying very hard to be helpful, may become angry. So how you process the pain and people's response to it influences your emotional reaction to it, which is very important because negative emotions, anger, fear, depression, all feed back in to make the pain experience even worse. And then there's a behavioral response to pain. We call that pain behavior. And initially, pain behavior is something that you do to avoid hurting more. So people start to move in a guarded fashion. They avoid activities that might aggravate their pain. They move in a way that somehow protects them. But those behaviors can become habitual. You start doing them without thinking about them, and even after you've healed, you may still engage in behaviors, and some of those could cause secondary pain problems and make the whole situation worse. How you respond behaviorally to pain also has a huge influence on other people. So if you're behaving in an irritable way because you hurt, that can have a huge impact on the people you care about in your family and your social environment. If you become quiet and withdrawn, again, that has an impact on other people and on your relationships with them. So it's very important to recognize what you're thinking, how you're emotionally suffering, how your behavior has changed. And it's also important to recognize how your behavior is influencing people around you, because it's very easy to make other people miserable when you're miserable. And it can lead to lots of difficulties in relationships that you don't want to have happen. So part of my job as a psychologist working with people who have chronic pain is to help them remain sensitive to other people. When you hurt, there's a natural tendency to focus on how miserable you are. And you kind of forget about other people sometimes, and that they may be suffering in a somewhat different way, and that you have to remain sensitive to others, otherwise relationships can suffer. So I have two goals as a psychologist working with people who have chronic pain. One is to control the pain as much as possible. So one way of doing that is to use distraction. And so, one distraction technique could be to count backwards from 1,000,000 by sevens. But that might work. It'll occupy your focus of attention, but it's not a very enjoyable thing to do. So, my view of distraction is to have as busy and active life as possible, to have things that you do on a daily basis that keep you focused and interested and stimulated so that you have less time to focus on pain. When people have injuries, they're physically limited in what they can do, and they're hurting, there's a tendency to want to stay home and not do anything. But then you have a whole lot more time to focus on pain, and pain can be worse. It's important to control fear and other negative emotions. The reality is if you have a fear that you're going to aggravate pain, your focus of attention is going to be on the area that hurts. Your brain will actually process pain signals much more readily when there's fear associated with that pain problem. Depression is certainly associated with increased pain. Same is true with anger. Relaxation techniques are very helpful. You can certainly reduce the pain caused by muscle tension by using relaxation. There's often a distraction component mixed in with relaxation. And then modifying beliefs and expectations. And one of the ways of doing that is to use techniques such as self-hypnosis to try to give yourself more positive expectations about your ability to manage pain or to lead an active lifestyle in spite of pain. In the University of Washington system, you have a richness of really good rehabilitation psychologists who have expertise in this area. So that's a treatment that is readily available in the Seattle area. The other part of my job, and maybe the one that occupies most of the time, is actually trying to help people prevent the unnecessary negative consequences of pain. So obviously you're not going to be thrilled and happy when you hurt, but I think you can also avoid severe depression, severe anger problems, and that's important. And so my job is to help people not let pain complicate their life any more than necessary. This is just a slide that gives you the current prevalence of all kinds of different mood disorders in the United States, and this is in a population of people without pain versus with pain. These are not spinal cord injured individuals. But as you can see, the prevalence of emotional disorders is 2 to 3 times greater when someone has a pain problem. So pain really does cause emotional difficulties for people. The prevalence of chronic pain and prevalence of major depression for people with back and neck pain is 15.7%. The similar figure for individuals with chronic pain and spinal cord injury has been around 30%. But I think it's important to recognize that it really, whether or not someone gets depressed and how depressed is influenced by how much the pain or the injury influences the quality of your life. So the people that we work with in the pain management program, almost all of them are not working. They've suffered severe financial losses. Quality of life has changed significantly, and the prevalence of depression is closer to 45% in that group. So kind of, you know, when you've suffered more changes, you're going to have more emotional distress associated with it. So one way of managing depression is to change how you think about situations. So when someone has, you know, this is a simple model of cognitive restructuring, and those of you who have had any psychological treatment have probably seen something like this. But activating events can include situations of having chronic pain. That can be an activating event. How you think about that chronic pain can influence how it affects you emotionally, how it affects your behavior pattern, and to some extent some physiological changes. So if you think that pain is a sign of something dangerous going on in your body, then you might stop moving. So that's a behavioral change that can then lead to kind of worse conditioning and a loss of function, and certainly loss of ability to enjoy life. So a part of the process of managing emotions is to become more aware of how you're thinking about what's going on in your life, and to see if there's a more rational way or a more optimistic way of evaluating that situation so that you can minimize some of the negative emotional consequences. Changing behavior is also very important. So when someone becomes depressed, there's a tendency to view everything in a negative light. And so the person who's depressed doesn't feel like doing anything. They don't think they're going to enjoy themselves. They don't want to get together with friends because it's too much trouble. They wouldn't have a good time anyway. And so they tend to kind of view everything in a negative light, and they stop doing things. And it's important to self-manage depression, to maintain an active lifestyle, which should include exercise, involvement in social activities, doing something productive, and it could be washing the dishes. I mean, because after you wash the dishes, it feels good to have a clean kitchen. And so doing something productive is important. Doing something that's rewarding to you, or that you just take pleasure or enjoyment from, and having some fun, having you know, the ability to laugh. So you have people who are depressed often have to force themselves to get out and do some of these things because they don't feel like doing them. So you really have to make yourself do it. And then problem solving is another important strategy to manage depression. The reality is most people, I think, are depressed not because of a biochemical abnormality in their brain, but they're depressed because their life isn't what they want it to be. They're not doing the things that they want to do. Their marriage isn't quite as positive as they would like it to be. Their relationships aren't as good. They're not doing anything fun and interesting. And so I think you have to do some problem solving so that the quality of your life is closer to what you would like it to be. And that's probably the best solution for depression. So sometimes getting out and socializing more, calling up a friend, trying to do something to make your relationship with your partner more positive. And little by little, you can create a better life for yourself, and depression will automatically diminish. So a couple cautions about treatment for depression. The kind of the standard of care, if someone's depressed, they see their doctor, you'll get a prescription for an antidepressant medication. And this is a bill of goods that we've been sold that may not be completely accurate. So it's clear the research coming out now is that antidepressant medications are probably far less effective than we used to think they were, especially for mild and moderate cases of depression. So they're not the cure-all that some of the pharmaceutical companies would like us to believe. So it's important that you don't rely just on an antidepressant if you're feeling depressed. You want to still make the behavioral changes and the cognitive changes that'll help you get rid of that depression. And then another caution is if you're going to get counseling, psychotherapy, psychotherapy is not all the same. And so the therapies that are demonstrated to be effective for treating depression is cognitive behavioral therapy, which is a process of systematically changing your thoughts, looking at things in a different way, and changing your behaviors. And that's helpful. Interpersonal therapy is a type of therapy that's mostly focused on improving problems in your relationship, solving problems. And that's shown to be effective. Supportive counseling, which is, I think, what most people get when they see a counselor, may not be very effective. If you're going and you're talking to somebody and they're listening in a supportive way and being encouraging, that may not be enough to actually overcome a significant depression. So usually good therapy involves, learning something, trying out new skills, completing homework assignments, doing something that involves you changing your thought processes and your behaviors. Fear avoidance is a big topic in the chronic pain field. Fear avoidance simply means that when people are afraid that moving or engaging in activity will cause more pain or cause an injury, they tend to avoid being active. And this is a factor that's as common in individuals with spinal cord injuries as in other types of chronic pain. And so there are, what are referred to as catastrophic thoughts. So when you think that moving in this way is going to cause some horrible problem, that's a thought that will create pain-related fear, and that fear is going to cause you to avoid movement or activity that you think is going to make you worse. But if you do that too much, then you lose fitness, you lose conditioning, you might end up not being out and about as much, so you're going to be more isolated, and that can lead to depression and a whole downward spiral. So it's important to maintain a good level of activity and to know what is safe to do. Certainly don't do things that are dangerous, but I think sometimes people don't know what's safe and what isn't, and sometimes one of your providers can help you recognize what is possible. Anxiety and fear are normal. We all have them. And normal anxiety and fear are caused by a realistic expectation that something bad is going to happen. Pathological or abnormal fear and anxiety are caused by over-predicting the probability that something bad will happen. So when people have fear avoidance beliefs regarding pain, sometimes people over-predict the possibility of something bad happening if they move in this way or they do this. So one way to overcome this excessive pain-related fear is by the cognitive restructuring that I talked about for depression. So trying to identify what are the thoughts and beliefs you have about moving and what that'll do to you, and to try to rethink that so you're looking at it as objectively as possible. The best way to overcome fear is exposure, facing the thing that you're afraid of. So if you're afraid of dogs, you have to be around dogs to overcome that fear. If someone's afraid of movement, you have to move. You have to actually engage in activities. Somebody can tell you it's safe, but until you do it and nothing horrible happens, it'll be hard to overcome your fear. So gradually, approaching an activity. So starting out with a little bit of something. So if your goal is to spend 3 hours out cruising around, you start out with 2 minutes or 3 minutes or 4 minutes. You gradually try to build up your endurance and your ability to do something. And you do it at a pace where you can last the length of time that you want to and make sure that you use the correct technique for doing things. But people can become much more active than they think they can. Most of us hold ourselves back because we're kind of afraid we can't do something. And so often people can accomplish much more than they realize. This is an example. This picture is a gentleman named Mark Wellman who has paraplegia, but he climbed up there. So he's a rock climber. On the website there's lots of pictures of him scaling this sheer rock face. So he probably didn't start with that. He probably started with a little bit of that activity and worked his way up to it. And then it's important to pay attention to your relationships. So again, when people hurt, you know, you want to be left alone. Most people, when they feel sick, they want to be left alone. They don't want to talk to anybody. But if you have pain all the time, there's a tendency that you will withdraw, and that can drive people away from you. And you lose an important part of your life by doing that. If you're grouchy and grumpy and irritable because you're hurt, you might, again, lose a lot of relationships. You can very quickly drive people away from you. So I think it's important you, again, maintain that sensitivity to the people around you so that you don't make them miserable, because you need people in your life. It's important to be aware that your pain behavior has effects on others. People see you grimacing, they see you being quiet, they see you acting grumpy, they see you not moving, and that concerns other people, that bothers other people, that distresses other people, and it changes how they treat you. And sometimes relationships become unbalanced. They're not quite the same. Someone can become a caretaker instead of a partner when you don't really need that. So it's important to be aware of what you're doing, how it's affecting other people. It's important not to make others guess what you want. I think when people are around someone who is in pain, they don't know whether they should say, "How's your pain today?" Because your response might be, "Well, until you brought it up, you know, it was fine, but now that you brought my attention to it, it hurts." Of course, if you don't ask, then they'll say, "Well, they don't care." They don't even ask. So don't make people guess what you want. You know, it's easier on the other person if you tell them that you like to be asked how you're feeling, or if you like to be asked if you need help with something. If you don't want to be asked, then it's okay to tell them that. And people are generally happy to respond to you the way you want, but you know, they can't read your mind. They don't know what it is. So you want them to be sensitive to you. I think it's important that you be sensitive to others. When people see someone in pain or someone struggling physically, they feel obligated to do something to help you. And sometimes there isn't anything they can do to help you, and then they feel guilty. And so people around you who see you suffering sometimes feel pretty miserable because they feel helpless. They feel like there's nothing they can do. Telling them there's nothing that they need to do lets them off the hook. Or telling them how they can help will then give them some direction. And you want others to be sensitive to you. And again, this is the same issue. Is it's important to speak up and tell them and let them know who you are and what you want and what you need and how you expect to be treated, so that you have good communication in your relationships and people aren't always guessing who wants what from someone. Okay. I think that's my last slide. Thank you. Yeah, the question was, we all work together in the same clinic, so we talk to each other all the time. The question was, what if you have one provider here and another one across town, and how do you handle that so that there's kind of some cohesion in treatment? And I think asking people to talk to each other. I mean, so I've had patients ask me, would I mind calling their primary care doctor, or would I mind calling their other mental health counselor? And so I think getting them to communicate and send notes back and forth to each other, and maybe even have a conference, a telephone conference, so that everybody's on the same page and working together. You know, we strongly believe that a team approach is the way to go. So you want to try to create a team as much as you can. Any other thoughts?
Yeah, coming from a therapy perspective, you know, as a therapist, the first thing I want to know is that, you know, this is not a medical issue that needs to be addressed either with medicine or surgery or some sort of intervention out of my domain. So as you work with either your PT or your OT, that's the first thing that they're going to want to know. And so a call from a physician or a discussion with a physician is really important for me. So that when I'm working with someone, I know that the things that I'm offering for them and suggesting to them and helping them with really are safe, because that's what I'm telling them, and really are appropriate. And in that context that can help me help someone that's having difficulty or particularly with a pain problem move forward. It's much easier for me to get someone to work through pain and discomfort when I know that yes, they've been fully evaluated medically, and this is really a pain problem and not say something unstable medically. So I think if you're following my suggestion of making contact with a therapist for just kind of a brush up on your exercise plan, the first thing they're going to want to know is that you're medically stable and ready to participate in those activities.
Yeah, rehab doctors, that's how we're trained. We're all trained in a team. Even in my private practice, I frequently call the physical therapist. I frequently call other people. It's part of what I do as a physician. A family physician or other physicians, it might take a little bit of cajoling. You might really have to tell them, this is really important to me, because they might not be used to it. But most therapists, and then when I call a therapist, I've never had a therapist say, no, I don't have time, don't call me in the future. Therapists are clearly already in the mood to be sort of a team project. So I think most of the time, if you let your needs known, you can kind of get what you want. And if it's not a rehab doctor, you might have to help them along. Well, so we know that opioids change the chemical milieu of the spinal cord. They change the map in the brain. Has this been shown in other classes of medication? And I know that, well, do you know?
I'm not aware of any.
Okay. No, we do know that there's less norepinephrine in the spinal cord fluid if people have chronic pain, but they haven't really connected that to changing the chemical structure the way that opioids have been found to do. As I mentioned earlier, the brain has, and the nervous system has ways to shut the pain signal off in the spinal cord and coming down from the brain. For some reason, opioids, they tend to inhibit this ability to shut the pain signal off. And I don't know that other medications have been found to do that.
I have a question for the group. How many people have an established exercise program that they do every day? Okay, that's not enough. That needs to be everybody, okay? I assume
A lot
you're
of
all
guilty
here
faces out
because
there.
you're interested in managing your chronic pain, and exercise is a huge part of that. How many people have regular contact with a PT or an OT that helps them with their movement patterns? Not enough. Everybody got a take-home message from today? Okay. Look in that address book, talk to friends, talk to your physician, and get in contact with someone. I could teach someone a good home exercise program that would really go a long ways to not only addressing musculoskeletal components of things that I would see, and wheelchair users have real specific musculoskeletal needs, but also to help people address chronic pain. It wouldn't take many visits, 2, 3, 4 visits, to really help someone establish a very good home exercise program that they could do every day that would not only go a long way towards supporting just general health and functional activity, but towards managing pain. So maybe if we ever come back, I'll get everybody to raise their hand when I ask that question.
So her question was a son who's 27 months after a spinal cord injury, and his pain is like T2 to T6. Where is his injury?
Oh, T2 through 5 repressed.
Okay, so that's kind of around his... yeah, so if we spent some time sort of trying to characterize it, it's chronic. It seems to be maybe more neuropathic related to a spinal cord injury. And again, what you have to have is a physician who's willing to try a variety of medications, but sometimes they don't work. And to never underestimate the importance of psychology and good sleep habits and trying to decrease your fear, because sometimes in the end, that's going to be all that you have left. And the person who figures out chronic pain is going to be a millionaire. The person who can figure out why the spinal cord and the nervous system didn't shut off like it's supposed to, that's a hot area of topic, and we wish we could figure it out.
Just a small thing to add to that is for most of the patients that I see, their pain isn't going to go away, and that's one of the first messages we give people. So then what? Right? So we're dealing with the then what. So how do you manage the fact that that pain's not going to go away and still have a good quality of life? And it takes a team approach to help the person, but the person has to do some activities on their own to deal with that. Anything to add to that?
The question was, how long
Oh,
should you try anticonvulsants, gabapentin, etc., to give them a chance to work?
That's right. So, most people would say several weeks. Clearly, 1 or 2 days, it's not going to be enough. And with gabapentin, every doctor's different. I do it at night, start at night and slowly increase it. Once you get up to about 900, 1,200 milligrams at night at one dose, in my experience, if you haven't seen anything, nothing's happening, it's not going to work. Other doctors take it all the way up to the max, 3,600, maybe 4,000 milligrams, and try it up there for a while before you come down. So I'd say weeks. It's not going to be days. And you want to make sure, like I said, that you're sort of directing your care and you're thinking about, what is it that I hope to get from this? Sleep aid, numbness and tingling benefits, maybe a mood benefit, because some of that stuff, or all of it, the physician has no way of knowing whether or not it was effective. So completely different than a blood pressure medicine, where you come in and I do all the monitoring and I check it and I'm going to decide whether this is working. All of these medications for pain, really it's up to the patient. The patient has to be able to say whether or not it was helping. How about you, Dr. Burns? Is that weeks to months for that?
Yeah, I think a trial of 6 to 8 weeks is probably plenty on that sort of medication. I wouldn't expect somebody would have a response if they hadn't already at that point and were already up to a maximal dose. And people respond differently. Some people respond better to one medicine than another in the same class. But I think it's very important to assess the response someone has had and decide, is it worth it? What sort of side effects are we experiencing? Keeping in mind that side effects can be additive. Some patients are on 4 or 5 different medicines that are sedating to affect their bladder function, to affect their spasticity, to affect their pain. There's some preliminary research coming out showing some major effects on cognition from gabapentin, and that research needs to be extended a bit to say, but it's something we really need to be cautious about. We need to pull medications back if we're really not seeing a benefit, instead of just adding a second and third and fourth one.
Questions about marijuana. Sometimes when patients ask about this, I like to say, my education about marijuana in medical school was almost zero. It's not something that I use or know any colleagues who do. And so I think Jim has a little information. I don't know if you do some. Oh. Anything you want to say about?
Well, I think there's really not a whole lot of data on how effective marijuana is. There certainly is some research showing that it may impact one of the opioid receptors, and certainly I hear anecdotal reports all the time from patients that it's the one thing that helps them, and probably not nearly as harmful as many of the medications on the market that are being prescribed. It's illegal, but it's not being enforced, at least in Seattle. Smoking it is probably not the healthiest way to ingest the drug, but people can consume it other ways. So it's a judgment call, I think, and I see more and more patients using it, and I think we'll know more in another 10 years about how effective it can be.
One other quick thing about the marijuana and how in a chronic pain setting we sort of tend to lump it in. In addition, similar to opioids, which are great anti-anxiety medications, sometimes people can get into a situation where they have chronic pain where they become relatively dependent on their opioids for their anti-anxiety effect. And frequently it's not something that's really conscious to them. And what happens frequently, because pain and anxiety is so interrelated to a pain, is that what we're ending up treating is really an untreated anxiety problem, and it's getting treated with opioids or perhaps with marijuana. And as a physician, that's what my concern would be, is that we would get into a situation where really what I'm treating is an anxiety problem with a medication that's not the best anxiety treatment. And so that would be another sort of slippery slope for me, recommending marijuana, which is a great anti-anxiety medicine for a patient who has chronic pain, because that could be an issue.
What about methadone? You haven't
So methadone is a long-acting opioid. The longer-acting ones tend to give people less of a buzz and sort of less addictive, if you will. However, when it comes to chronic pain, the jury is still a little bit out on the advantage of long-acting opioids for chronic pain. Up until, even the last 5 years, it's been the mainstay of treatment. Now there's more and more evidence that ongoing chronic opioids actually can make people's pain worse. It can make it spread. So methadone is a good choice when you're picking a long-acting one, less sort of addictive. The trend is now away from long-acting opioids.
Yeah.
Other names would be Opana, MS-Contin, OxyContin. All of those are long-acting opioids.
Mm-hmm.
And there is some evidence that for some people, if you switch it up, one does happen to work better than another, or sometimes if somebody's been on one for a long time, they switch it to a different one.
Important to recognize that with the opioids, though, within a short period of time, you develop a tolerance to their effects, and then you have to increase the dose to continue to get the same pain relief. And people can end up with, we've seen patients taking 2,000 milligrams of OxyContin a day, horrible pain, they're totally tolerant to the medicine. So I think it's not a medicine that ever is terribly effective. We have tapered, for chronic pain, we've tapered literally thousands of people off opioids. And if you ask them, how's your pain now that you're off, they'd say, it's still there, but it's no worse. But I feel so much better. My mind's better, I'm not so moody and grouchy, and I sleep better. And so generally people feel better without it. There's more recent evidence that it creates opioid-induced hyperalgesia, so it actually makes pain worse. And that can be done with modest doses for as little as 4 weeks. You can actually create a worse problem. So I think it's not a great treatment for pain that becomes chronic.
Other good medications that sort of hit several things are the tricyclic antidepressants, amitriptyline, nortriptyline, dizipramine. They help with sleep, help with pain, sometimes help with mood, even though you're not really treating that. Cymbalta is the new one. That one's kind of hit or miss. I've had a lot of people who've had like a lot of pain relief on it. Their pain is just gone. Other people not really doing as much. But normally I start with Neurontin.
There's certainly evidence that depression is greater in people who are unemployed than people who are employed. That's setting pain aside. Certainly it's my experience, and I think there's some data that supports this as well, is that the more pain impacts your life. So if you're not able to work, if you suffer financial loss because of it, and all the social interaction in the work environment and the personal satisfaction from doing it, that's a factor that's going to add to depression. So I think not working is a big factor.
Yeah, I'd have to agree. Where I am at RIW, it's almost exclusively injured workers. So now I don't have the injured non-worker seeing so much of that. But certainly among injured workers, it does seem that once people stop working, really everything can tend to implode.
I guess, Dr. Burgess, my question is, those people that you're treating that do return to work, do their symptoms decrease in both pain and depression?
Yeah, I would say definitely.
Work is a distraction. It's a great distraction.
It's a distraction. Once you have financial control and power, now you don't have so much worry. Frequently, although people say, like I just had someone today who said they can't turn their neck when they're looking in the car, but when they go to work, they're talking to people, they're bending and reaching. That's way more therapy than you'd ever get in 2 hours a week at PT. So a lot of activity, socializing. There's just almost no end to the list of why getting back into life is better. And when it changes your pain, when psychological things change your pain, it's real pain. The brain lights up on the MRI, just like pain that's brand new from an acute musculoskeletal injury when it's contributed to by psychological factors. So it's all real. It's never imaginary.
Just to add that, it doesn't necessarily have to be work. I think doing volunteer activity is valuable. Having some social interaction or a hobby that you love or a craft activity that you like doing. I think it's important to have something that you do that gives your life meaning and ideally gets you out around other people.
So in the interest of time, I'd like to wrap up the formal question and answer session right now. Thank everyone for some excellent questions, and thank our three speakers tonight.
Thank you.